on STMI with hemodynamic compromise. So let us enjoy his talk.
So it is a problem, particularly in the US, that the emergency room doctors, they call for STEMI activation. And then we wonder whether first it is a STEMI or not. And then we look for whether this is true STEMI. And then sometimes we see that there's some hemodynamic compromise. So I'll focus on the hemodynamic part, but Dr. Guzman mentioned about soccer, but I will tell you about cricket because I get a lot of inspiration from the cricket captains when I deal with the STEMI because it is running with the time and then limited overs, so a lot of issues. So can I have my slides, please? So I'll start with some cases. So let me tell you something, and maybe I just buy time, that when there is a STEMI activation, I tell my fellows that it is two part, the ST elevation and the MI part. The ST elevation, as you know, there are STEMI mimics, ST elevation mimics. It could be left bundle, it could be LV aneurysm, it could be the hyperkalemia and LVH. A lot of mimics, and I request you to read the NAJM paper about the STEMI mimics, but that is one type of STEMI presentation mimic. Yeah. The other one is the STEMI, but pathophysiologically, it may not be type 1 MI, but it presents with the STEMI. So 49-year-old who come in with hypertension smoking, and then this EKG, and then you see that there is a significant ST elevations in the precordial leads, and also watch the inferior leads as well. So when we went to the lab, we found this. So when there is a two coronaries presenting with the culprit, both occluded, we opted to go with the temporary pacer and the RCA intervention first. And then we'll go for the LAD. I'm not sure why it is not moving. So anyway, so there are some impending hemodynamic disaster. And if you look at this EKG, it is a true posterior, which is not that common. And then if you look at the echo, and that is another talk that everybody coming to the ER with the impending hemodynamic compromise, I think we should do echo at bedside. So this patient, what's happening here? Maybe I should have done what Ramesh is going to do, that use your own computer. So this was a circumflex, and then we treated that. But question is, you always wonder what kind of precautions you need to do. So I usually check the EDP, end diastolic pressure, look at the whether the patient is in impending shock or not. And this is actually an important issue because if you look at this patient, 53-year-old who came in with inferior ST, and then this EKG, but watch, this patient is tachycardic. And I worry when the patient is tachycardic and the patient had significant LAD circumflex, EDP high, and we also did a quick right heart. Then this is severe LV dysfunction, and patient was in shock. So the question is, what we do in this situation when we know the patient is already in a shock. And I'm sure Ramesh is going to talk on the sky shock and then the class C. Then you immediately differentiate whether this is LV, RV, or BIV, or it is any valve disease associated, or there is any tamponade. So these are quick assessment for the sky shock from A to E, but also it is important to identify the etiology. We assess the LV function, then we assess the cardiac power output, and then we think about whether we need to unload. So if there is a shock already and the name of the game is the loading, then it is better to unload, because as you know, we have to do this debate is over, this balloon pump or impeller. Question is, what kind of problem you are in? The balloon pump is going to do some coronary perfusion, it's not going to unload. So if the name of the game is unload, then you'll have to do the unloading mechanism. If we don't, then it will be rapidly going into the tissue perfusion problem, and you will have the multi-organ failure. So if we do unload, it is not, Dr. Guzman showed you some slides, it's not proven that unloading conceptually is going to make an impact yet, but we are heading there. In our patients, we put an impeller quickly, and then we stabilize, the flow is good, we did the circumflex, and it is a situation and judgment issue that should we come out with complete revascularization to get the best on this patient. And Professor Azam mentioned about what we need to do in a situation with multi-vessel disease. I try not to, but if it is a threatened vessel or both are culprit, then I try to go for this. So another patient, young, who comes in with this ST elevation, and if you look at this, the case, patient went into cardiogenic shock, intubated, and this LV function is poor. And the important issue on this case was that the patient collapsed, and first rhythm was PEA, and we did not take to the cath lab. And then we found that the patient has intracranial bleed. So not all STEMIs are equal. I'm going to come to that in a moment. So 40-year-old with a BMI 40 and this EKG, ST segment elevation in the precordial least watch. This is sinus tachycardia. As we are evaluating, patient goes into VP arrest. And already after arrest, it is very important to assess quickly the patient return of a spontaneous circulation, and it is shock or not shock. And then this patient was in shock. We did the right heart cath, and then we did the cardiac power output, escalating doses of pressors. We put the patient on the echo, and then look at the cath. And I showed this, that you can see there is a spontaneous coronary dissection, and we try to unload, and I deliberately did not go after that LAD. And so we buy time, give the hemodynamic support. Few days later, patient gets better with wind off, and then because of the probability of VP arrest, and we did not vascularize, we talked to our electrophysiology guys, and they suggested that we ICD, and then patient had a repeat cath, and you can see it's healed. So not all STEMIs are equal. You need to understand the pathophysiologic mechanism and what we need to do in certain situations. Let me go through one more case. So this is a patient who watched 86-year-old and brought by the EMS and found unconscious, and patient had some fever a few days ago, and this ST elevation was there, and we learned from the COVID time that some of them may mimic like the Takasubo. What we did actually in many cases during the COVID time, because of this experience, although there was ST elevation and presentation is like this, and you can see that the LV aneurysm, and we published by the echo. If the clinical presentation and the echo findings are consistent with the Takasubo, we did not. This is us. We published this almost 15 years ago. That then we don't take to the cath lab. So 67-year-old, and then this EKG. But listen, this patient is a transgender, and then patient had this estrogen therapy, VP-virus, recurrent shock. And this EKG, I call this shark fin ST elevation, and we have shown that those with the shark fin presentation, and there is a cohort where it is called the pectoral fin. These patients are terribly sick and they don't do very well, and their prognosis is probably almost uniformly bad. And this was the echo. And as you can see, the LV is not great. The CT was negative. But when we did the cath, then we see this. So the culprit was RCA, and this was penumbra catheter was used. Ultimately, Nasser mentioned about the slow flow thrombus burden, but we did the good. PCI, but the reason I'm showing this, that patient had significant anoxic encephalopathy. So what I'm trying to mention that if the downtime is too long, and even if there is a culprit, you need to assess whether it is worth going after these patients for invasive strategy or not. And there should be a discussion on this. 90-year-old chest pain, and this patient had a cath and had a VSD, delayed presentation with the VSD. And the question is, what we do with these patients? So in summary, the ST elevation MI, it can mimic that with the EKG, or it can mimic the EKG and the presentation. All can be STEMI, but it may not be pathophysiologically what we call the type 1 MI. It can be SCAD, it can be Takasubu. So we need to be very careful about what we are dealing with. And then we have these challenging situations, multivessel left main, bifurcation, ad hoc bifurcation, calcification, CTO with the STEMI, and then STEMI with mechanical complications. So STEMI is a whole spectrum, and by any means, all STEMIs are not equal. Thank you.